Hello, good evening, ladies and gentlemen. Hope we are doing great. I'll unmute everybody so that you can hear your voice and welcome each other to this program. And we hope others will join as soon as possible. Hello, how are you doing?
Good evening.
Good evening, Doctor.
Good evening, sir.
Everyone, good evening.
We are glad to be here. It's been quite a while.
Be with you again.
Good evening, everyone.
Hi, everyone.
Good evening.
Good evening.
Are you all doing
Good evening, everyone.
Good evening, sir. Good evening,
good?
everyone.
Good evening.
I can
Continue
see
now.
Good evening, sir.
Good evening, everybody. I'm going to meet everybody.
Well done, everyone.
If you have friends,
Nice to meet everyone
if you
here.
have friends in the class that are not
Wonderful
here,
time in class.
Good evening.
yeah, if you have any friend that is in the class that is not here, please tell them to come on board immediately. First of all, I need to use this moment to apologize for the snag we had in the process of the internship, but don't worry, it's going to end very, very well. And you're going to be excited you took this program with us. And for those of you that have not been posted, please just join the forensic. You will love it, you will like it, you will thank us for it. And if you have been posted somewhere doing your internship, just join the forensic. Make sure you don't miss any moment with us. Yes, thank you very much. I'll be inviting Joy Ativie. She's a well-groomed expert in mental health care delivery. She's also a testimony to what we've been doing. She recently got an appointment working with a firm in US. She is right here in Nigeria working with a firm in US on the basis of our mental health level 3 program she did. And she's also a seasoned NGO administrator and consultant. You'll be listening to her, and please just give her your ears and you'll be surprised at the amount of things you're going to learn. This program is one that is not just going to end in you becoming a mental health level 3 caregiver, but you're also going to be able to develop a skill to earn income from people that need support from outside this country or from outside your state or your location. It's going to be a skill you will learn that is ordinarily not part of this program, but we decided to include it because of the current realities on ground. So over to you, Joy. Welcome to this program. I'm going to make you the host so that you can take over the program. Thank you.
Hello, good evening, everyone. Okay, I am Joy Ativie, and I will be your lecturer for tonight. If you attended the grant and proposal writing, I'm sure you already know me. So today we'll be looking at trauma-informed care. All right, so today I'll be sharing with you materials in a slide, and with that, so that those who want to make screenshots and also write notes while this training is going on, this forensic program is going on, you can do that as well. Okay. All right, so I would like to know, can you all hear me? If you can hear me, I would like you to put it in the chats that you can hear me. Okay, great. Yeah, thank you very much. I've seen that. I'm glad that you can all hear me. Okay, so I'll start sharing the screen now and we'll delve into lectures right away. Get your writing materials, your biro, your writing pads, and let's have a great evening tonight. Thank you. All right, so yeah, we are looking at trauma-informed care. And first of all, we'll be looking at the background, how this whole thing came about, and the future of trauma-informed care, where we currently are, and the things that we are going to, how we are going to implement trauma-informed care in our society today. Because when we talk about mental health, we cannot just have the wrong idea of what mental health is, because right now you have done your level 2 and 3, you are currently rounding up your level 3. But if you do not have the right foundation when administering diagnosis and giving therapeutic counseling to victims and clients, you might get it all wrong. So it is important that the approach of trauma-informed care is carried out in mental health therapy. All right, so yeah, let's look at that. Trauma-informed approaches emerge partly in response to research demonstrating that trauma is widespread across society. Yeah, so we have left the level, that's the level of what is wrong with you, to considering what happened to you. I'm sure many of us can relate with that. Previously, when we see somebody who is troubled, somebody who is having a lot of difficulty, you say, what is wrong with you? Are you mad? A lot of things like that. Before, people were tied up. When you see people misbehaving, acting, abnormally, the first thing people get to do is to tie them up, is to shackle them, is to restrict them. Is not to care what could be the cause of that action or their reactions, So we have left that level of what is wrong with you. We have left that level of this one has gone mad. Remember, you can't use the word mad as a therapist. You are not allowed to do that. So keep that at the back of your mind. All right, now we are in the level of, we are considering what happened to you. Okay, so with this, we are looking at how trauma-informed approaches to mental health care has, brought about the best of mental health care, the best of service providing. It also describes how past trauma can be understood as the cause of mental distress for many service users. When I say service users, you should know that I'm talking about our clients, we are talking about victims of different traumas who you are going to be dealing with in the nearest future, okay? And now, not only about the clients, we are also talking about you yourself as a service provider, okay? You are offering the service of trauma-informed care. You are offering the service of a mental health therapist. You're offering the service of a health practitioner. You're offering the service of maybe a staff in an organization, okay? You're offering the service of a staff in an organization, all right? Now you need to know how you can even take care of yourself. Trauma-informed care teaches you how you can manage yourself as a service provider. Because if you do not manage yourself rightly, you can get traumatized by another person's trauma. I hope you got that. It is very important to note that you can get traumatized by another person's trauma. I'm seeing your hands up, but just I would ask us to have a little patience with me. I'm going to be taking your questions sooner or later, and just follow the class, okay? So I would like you to put your hands down. Yeah, So let us look at a little background of this as well. The World Health Organization conceptualizes mental health as a state of well-being in which individuals realize his or her own abilities and can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. Okay, so when this person, or when a particular set of people, or when you are given a case of somebody who cannot meet this level of mental health, you know that you have to offer service. A concept named trauma-informed care has invited evolutionary change in a variety of settings, including schools, healthcare organizations, prison, and social service agencies. This shift in culture has resulted in improved care to individuals who have histories of traumatic life events or toxic stress to heal and deal with their mental health needs. So now, I'm aware many of us, when we are given the chance to do our internship, many people were running to psychiatric hospitals. It is beyond that. In schools, you have a lot of children who have gone through traumatic experiences, who are currently going through abuse in their home. Not just abuse, children who are dealing with, or students who are dealing with broken homes, who are dealing with domestic violence or witnessing of domestic violence. We are seeing a lot of, things going on. So when you are looking at only psychiatric hospitals, it is the wrong thing. Take some time also to look at schools, look at prisons, look at NGOs, look at other social service agencies that you can offer your services to, offer this which you have learned, you can offer it to. All right, so let's move ahead. Okay. Just give me a minute, please. Yeah, okay. So we are looking at how to, we are looking at implementing a comprehensive trauma-informed approach. So trauma-informed care must involve both organizational and criminal practices. Clinical practices, okay? So this is beyond, you are just trying to, you are trying to be a doctor, you are performing your nurse duties. It is beyond that, or your medical duties. It is beyond that. You are looking at how you want to better the society. You are looking at how many more organizations can be a part of the movement of mental health awareness and incorporating it into every sphere of life. Okay, so there's a lot of widespread changes to organizational policies and culture, and this needs to be implemented for healthcare settings to become truly trauma-informed. Changing both organization and clinical practices to reflect the following core principles of trauma-informed approach to care is necessary to transform a healthcare setting. So now what we are talking about is this. You are in an organization, all of you right now in an organization, whether you are at the top or you are at the bottom, wherever you are placed, it is in the best interest for this mental health awareness to be preached, for the practice of trauma-informed approach to doing things to be preached. Okay, so for those who work in certain organizations where the staff are going through a lot of traumatic experiences, you find out that they cannot prioritize. You think they are lazy. People are not lazy. They are just traumatized. People are going through a lot, but many organizations, especially in Nigeria, do not care. And that is just wrong. Because you see some people, you hear that this person has a very good job, but he jumps into the lagoon to commit suicide, or he drinks sniper. A lot of things are going on. And until we begin to deal with daily activities from the approach of trauma-informed care, many things will still go wrong. Okay, so this culture needs to be implemented in organizations and in clinical practices as well. All right, you want to give a child injection, but you cannot, you are not trying to find out what exactly is going through this child's mind. And then at the sight of something sharp, a child jumps. It is not because of the fear of the injection. Sometimes it could be that the child has been attacked at home with sharp objects or punished with sharp objects. So you have to look into these things. Instead of you just concluding, you should find out what is happening. Not what is wrong, what happened, what is happening. I hope you are following the class. All right. Okay, so yeah. Now let's look at the importance of trauma-informed care. According to Substance Abuse and Mental Health Services Administration, a program, an organization, or a system that is trauma-informed realizes the universal impact of trauma. That is one. Two, these organizations or program recognizes the signs and symptoms of trauma in individuals involved with the system. It integrates knowledge about trauma into policies, procedures, and practices. This is very important in today's society because from this year, thank God a lot of us are becoming mentally aware, and a lot of us are getting this certification to put a lot of work into what we do as therapists. So right now we are going to be pushing for mental health to be incorporated into policies governing Nigeria, policies governing your country or your society. So it is not just about the service you are providing. It is about making sure that the knowledge about trauma enters into this phase, enter into the highest levels of decision making. Okay, can you all hear me? If you can hear me, please raise your hand. I want to be sure you can hear me. Okay, great. Thank you very much. You can put your hands down. All right, so it also seeks to actively resist re-traumatization. Employing universal trauma precaution assumes that every individual receiving services in that system has a history of traumas to actively resist re-traumatization. Now you ask me, what is re-traumatization? It is simple. Somebody comes to you for help, and in the process of offering your services, the person gets re-traumatized. That can happen if you do not handle the situation with trauma-informed care. You have to be informed of somebody's trauma. If not, the person will come to you and get worse. All right, so let's move on. Now we'll be looking at trauma. Okay? I hope you can see my screen. If you can see my screen, please let me know. I want to be sure that you can see my screen as well. Yeah. Okay. So the 3 E's in traumas, you have the events, the experience, and the effects. In short, the events are like circumstances, something that happened that caused the trauma. It could be medical, it could be physical, it could be psychological. It could come in different ways. These are events that happen. These are circumstances, bad circumstances that must have traumatized an individual. Now, for the experience, this time it is personal, okay? It is the individual that can interpret the event to be traumatic or not. And then you have the effects. That is what happens after this person has been traumatized. What can you see physically? What can you see emotionally about the person? Okay, what can you even see spiritually? Some people will say it's village people. It's not village people. This person has been traumatized, something has happened, all right? So I will go into the 3 E's of trauma in a moment so that you can understand better. Just get your pens and your paper ready. All right, so let's look at events. Events and circumstances may include actual or extreme threat of physical or psychological harm. That is natural disasters, violence, rape, or severe life-threatening neglect for a child that imperils healthy development. These events and circumstances may occur as a single occurrence or repeatedly over time. The individual experience of these events or circumstances help to determine whether it is traumatic or not. Okay, how the individual labels or assigns meanings to and is disrupted physically and psychologically by an event will contribute to whether or not it is experienced as traumatic. So you can understand what I'm trying to say here. What is traumatic for A might not be traumatic for B. And also there can be events that could be repeated. So this generates, this aggravates into a serious form of trauma, okay? If it is one time, it is traumatic, but it's when it has become more than once, it is repeatedly, it becomes chronic. I'll go into that in a short while. I will show you a lot about trauma so that you can really appreciate why you have to approach mental health with trauma-informed care. All right. So let's look at experiences. So this question, when we talk about experiences, they elicit a profound question of why me? You know, when you have gone through or when somebody has gone through a particular heart-rending event, the person is like, why me? The person is broken. The individual experience of this event or circumstances is shaped in the context of powerlessness and questioning. When you begin to ask God, God, why? Why my father? I felt that way as well. This is my own personal experience. I felt that way. Of all people, why my father? You feel helpless. There is nothing you can do. In cases of sexual abuse, you know, you see people, you see a lot of women or even men too, the feeling of humiliation, of guilt, shame, betrayal, or silence, you know, this shape the experience of that event. When a person experiences physical or sexual abuse, it is often accompanied by a sense of humiliation, which can lead the person to feel as though they are bad or dirty, leading to a sense of self-blame. You understand that? I don't know whether you have ever come across such a case. This is where you have to tell your clients that it is not their fault. It is not their fault that they were raped. It is not that their fault that their father raped them. You have to make them feel safe. In fact, they should be safe with you. It should be confidential. You have to give them hope from their current situation, not baseless hope. I mean hope from their current situation. All right. So this is your prerogative as a mental health therapist. Okay, let's move on. So let's talk about effects. Okay. So the long-lasting adverse effects of the event are a critical component of trauma. These adverse effects may occur immediately or may have a delayed onset. So you might have seen something like that. Somebody went through a lot as a child. She saw the parents divorce. She saw the parent divorce or something. And then when the person grows up, the person is growing up normally. She's from a broken home. And then you think everything is okay. Now it is time for her to get married. All of a sudden, she grows cold feet. She doesn't want to get married. She is actually scared of marriage. And this person knows what she's saying. She just cannot handle the thought of marriage. There is a fear coming from somewhere. I hope you can relate to that. Somebody has been involved in an accident, not once, not twice, or a plane crash. Now the person enters the vehicle and the person is shaking. You can see the fear, the person is shaking. These are adverse effects. You may not know what is going on. Okay, fine, or let me put it this way. The person was involved in an accident and then the person begins to enter vehicles. The day you buy a car for the person faints. From the perspective of somebody who is not trauma informed, what do you think? That person will think, is it when they bought a gift for this one that this one is fainting? No, there is an underlying trauma. The person cannot stand the inside of a car in the driver's seat. You need to understand that people are going through a whole lot. And it is your duty as graduating students of level 3 mental health that you begin to know these things and how to deal with situations like this. Numerous situations are going to come up. A lot are going to come up. You have to be emotionally stable and you have to be informed to be able to take care of such cases. Okay, so that's for effects. Let's move on. I wanted to talk about trauma a bit. Let's see if I can do that. Okay. Yeah, one moment. So, right, let's just go on. So we are looking at key ingredients for creating a trauma-informed approach to care, okay? So we look at the clinical approach. I would like you to know that, yeah, there is a lot of materials on this and it will be shared to you so that you can go through it all. I just have a very short time, but I'll just try to run through. But the materials will be available for you to go through. Okay, so we'll first look at the clinical approach. This involves patients in the treatment process. You don't do things just from your own mind. You ask questions, you ask the patient some questions, carry them along in the treatment process. Then screening for trauma. This one is very, very technical. While you are screening for trauma, you want to find out what is going on. Remember that you don't screen and screen again. You could re-traumatize your patients, okay? So maybe once or twice or once and a continuation to get your patients to begin to open up so that you can understand the cause of the trauma or the underlying trauma, okay? You don't, it's not like you screen this person today and then when the person comes next, you are not starting from where you stop, you go back to the beginning. causing the patients to keep reliving that traumatic experience, which might not be good. Sometimes the people, they want to block it, though it is wrong for you to allow your patient block those traumatic experiences, but put them in a situation where they can open up to you, a safe situation where they can do that. But when you put them in a situation where you force them to say what they are going through, and then they come again, you force them to say it again, you are causing a lot of danger. Then training staff in trauma-specific treatment approaches and engaging referral sources and partnering organizations. All right, so let us look at the organizational approach. All right, let's look at organizational approach. Yeah, you talk about leading and communicating about the transformation process. Okay, you don't keep this to yourself. You have your superiors. You have superiors that you talk to. When you are done with your sessions, when you are done with your therapy sessions, you speak with your supervisors. You talk about the transformation process. You talk about what is the next thing. You talk about solutions. You talk about yourself as well. You engage the patients in organizational planning. So when your organization or when you are putting your NGO, wherever you are working or wherever you are working, whenever you are planning something for these patients, you have to carry them along, because it is very wrong for them to come into something new when their minds are not prepared for it. You might make the situation even worse. Training clinical as well as non-clinical staff members. All right, so your staff members, your co-workers, they also need to be aware of trauma and follow trauma-informed approaches to dealing with people, so that when a victim is coming to see you, or when somebody you know who is traumatized is coming to see you, the person doesn't go through somebody, and that person who is not aware can just do something that can cause a spike in the person's negative behavioral change. Do you understand that? Then also we look at creating a safe environment. One, whether it is a shelter, whether it is your office, wherever you are working as a therapist, whether it is even online, it is important that your environment is safe, because of the lives of people, because of their personal stories. You do not want to be hurt. You do not want to be hurt if you are an online therapist. If it is a shelter, you do not want a position where an abuser gain access into the shelter where you are keeping victims and then come to abuse them again in that place. So that is why you do not know the location of shelters, except you are in the humanitarian field. You do not know the location of shelters. You just hear that there are shelters, there are safe houses. You don't know where they are. This is because a safe environment has to be created. Then you have to prevent secondary traumatic stress in staff. Whether they are your co-workers, whether they are your staff, the people working with you have to be stable up there. If you know that a staff member has gone through a similar abuse as a client, do not, except you are putting them in a support group, do not pair them together. Except you are putting them in a controlled support group, you cannot pair them together. If not, this person's trauma can reactivate the other person's trauma. Then also, what is good for your organization is hiring a trauma-informed workforce. So just in case you need to train your staff or you need to employ people who are trauma-informed. Now, this is also good for you because with your certificates, and if you want to get a promotion or get a new job, it is great to know that you are trauma-informed. So when you are coming into an organization, the people are safe with you. If it's an NGO, a UN job you want to get, your certificate will come in handy because you are trauma-informed. and you have practiced. You have gone through your forensic training as well. All right, so we'll quickly look at the questions and responses that are frequently asked, or how you should react or ask questions as a therapist. Okay, asking about trauma and abuse. It is very rare for trauma survivors to spontaneously disclose their trauma experiences. Yet, mental health practitioners often fear asking people about their past or current experiences of trauma. There is a need to focus on immediate concerns, fear of causing distress, fear of vicarious traumatization, diagnosing mental distress, and lacking training. Okay, so let me break this down for you. When somebody is brought to you, a prisoner is brought to you, or you are working with soldiers who just returned from the war front and have been through a lot of things, do not, if you are scared of asking about their experiences, please pass it to the next person who is emotionally stable to do so that you don't get traumatized yourself. Now, your trauma-informed approach comes in when you can get them to feel safe enough to tell you their story, to tell you what is causing them a lot of distress, how it relates with something they have gone through, maybe in childhood, and they are now seeing again. Just imagine in the nearest future, a child who has been through conflict areas where Boko Haram has attacked and was able to escape, now grows up to become a soldier. You understand that, and goes through a lot of trauma. So you can see the connection. It is expected that this young soldier will be traumatized, have symptoms of PTSD, you have PTSD as well, because this is primary trauma. This is chronic trauma happening. Okay. I wish I had enough time to tell you about the different kinds of trauma. I would see if I have that time, I would show you. Okay. So yeah, asking about trauma and abuse, it is recommended that practitioners ask everyone about their experiences of trauma and abuse. So ask yourself, whether your fellow colleagues, ask yourself about their experiences of trauma and abuse, so that you can deal with it, so that you know who to assign, so that when a case is coming to you, you know whether to take it or leave it. Okay? Ask at the initial assessment, but not during a crisis. You understand? So when a client comes to you, it is from the very beginning. You find a way. You find a way to meander into the person's innermost and ask your question. It is not when the person is acting, when the person is reacting to the trauma, when the person is not in the right frame of mind, that you now begin to ask questions. No, it is not at that time, because you are looking at it as what is wrong with you at that time. Remember, from the beginning, we talked about what is wrong with you and what happened. So at the initial assessment, that is when you should ask your what happened questions. Okay, what has happened before, what has gone on, not when the person is having a crisis. So you should ask in the context of the person's general psychosocial history. Let the person tell you what has, even when you are feeling that the person might be okay, or when the person feels is okay, let the person talk. A very common way I've used in service providing, I've asked the question, if your life was a movie, what will be the title? I have used that a lot. If your life was a movie, or ask yourself, if my life was a movie, what will be the title? Then from the title that your clients give to you, you can see, just from the title, you can be able to tell those who have gone through traumatic experiences and those who are currently going through something. Okay, and then you can now ask questions. Oh, I saw your movie title. It says, if I could turn back the hands of time. Can you tell me what would you like to turn back? you know, and then your client starts opening up and telling you about things that has happened. Now you can understand when your client is complaining about something, because trauma can cause a lot, from migraines to cancer to high blood pressure to a lot of things. So you have to know the underlying traumatic history, all right? So preface trauma questions with a brief normalizing statement. You know, that like what I was saying now, if your life was a movie, make it seem as though it's normal. It will get them to talk. Also make them know that a simple statement, I want you to know that you are safe with me. I want you to know that everything we talk about here is confidential. It is very important that you reassure them. So use specific questions with clear examples. I'm sure that you have gained a lot from me, because I'm asking you specific questions here. I've given examples of that. I've given examples of examples as well. Okay, so let's quickly run along. All right. So yeah, questions should be asked sensitively and at the person's pace. Remember, this is not about you. This is about your clients. When your client doesn't want to talk, you can talk about your experience. You can play. You can just say things, be friendly. If the person doesn't talk that whole week, walk at your client's pace. You do not force it until your client feels safe enough to know that they can tell you things. Okay? So service users should be reassured that they do not have to disclose abuse of trauma or trauma if they do not want to, and that they can refuse to answer questions. So don't be angry. If your client doesn't say anything, keep seeing your clients. Let them keep meeting their appointments. Keep seeing them. Just talk. One day, they will open up. All right? And when they open up and the floodgates of tears open, just show empathy. Don't pity. You are not talking about pity here. Don't show pity. Just show empathy. Okay? No hugging, no all that. Have a listening ear. Maybe those who are in Abuja who will be coming for the physical class will be able to get a lot of this, because I can see that I'm almost out of time. So a whole lot, I'll be showing you a whole lot in the physical training. All right, so it is important to have an understanding of dissociation commonly associated with trauma and be sensitive to this. Many people do not want to admit they are in denial. Some are blocking their traumatic, what they feel inside, their feelings. They are blocking it. They are dissociating themselves from it. So you just try, they are becoming numb. So you should understand that. And when individuals choose not to disclose traumatic experiences or are unable to do so, you need to be receptive to this and to be able to recognize the signs associated with previous trauma without the need for full disclosure. You can understand that. Well, I can see a lot of Africans here. The same way your mother uses I to talk to you and you understand, it is the same way you can be able to tell that your client is clearly traumatized and is not ready to open up. Okay? So there is a lot of words said in silence. That is the intelligence of a trauma-informed mental health therapist. Okay, yeah, just one more. Okay, so asking about trauma and abuse, all right? Yeah, so when a person discloses trauma and abuse, it is recommended that the practitioner responds in the following way. Reassure the person that disclosure is a good thing. Yes, it is. Knowing that the disclosure is also highly confidential. Please, if you're a gossip, yeah, if you're a pastor or imam or something that like to go somewhere, I can see some of you laughing. I'm serious. This is not the time for you to now go to your church and announce. That was how I interviewed somebody came for counseling and started. And don't do that. Don't do that. In fact, when you are signing your form, from your assessment, you should put it there. That clause has to be there, that your whole appointments are confidential. So don't go announcing. You cannot be a gossip and do this work. You get arrested and you will lose your license. You can't do that, okay? Do not try to ascertain the details of the trauma or abuse. Don't assume, okay? Let the person tell you. Let the person tell you the details. Let them say their stories. There are different ways that you can get that. Yeah, I'll give you another way that I use. I'll give you another tactics that I use. Those who like to draw. Can you draw your experience? If there was something that you experienced or something that you would like to change, what is that place that you don't want to tell anybody? Can you draw it for me? And then people use their artistic gifts to draw things. Some people just draw. You just give them a board, draw whatever. And then people start drawing. And when they start drawing, you are wondering, oh my God, did this come from somebody's mind? You understand? So don't try to assume, okay? Let the person, it's as far as they are beginning to disclose, you are making a lot of progress. Ask if anyone has been told previously and how that went. Yeah, some people can face a lot of betrayal. They told their friends how they were raped or something, and it escalated. It caused a lot of stigma and a lot of things. You can ask, when the person has started disclosing, you can ask that question as well and know how the person felt. So if the person needs to cry and all that, allow it, okay? Offer trauma-specific support and know how to refer people to it. So if it's a case where the person is beginning to have a lot of medical issues, or the person will start needing medications, you know how to refer the person to the right set of people. If it's in the case where the person is becoming very obese, you know how to refer the person to a dietitian, a coach, and all that. So you can see how that's what you can see the connections between these things, okay? Ask whether the trauma is related to their current difficulties. As I said from the beginning, you see somebody and you'll be shouting, you are a lazy human being, you are lazy. The person is not lazy. The person is going through trauma, It's a serious traumatic experience. And one thing about trauma is that it changes the priority of the mind. You would think somebody is beaten by fly. The person just wants to sleep. In everything, the person rather stays unconscious than to face reality. So you see alcoholics, you see somebody that just can't get up to do anything, you see somebody that just indulge in whatever. Don't write the person off. You as a trauma-informed mental health practitioner knows what is going on. So when other people are saying nay, you know how to say yay, and then you call the person and ask, what happened? It's okay to tell me. It's okay. Sometimes I feel lazy as well. You know, there are days I don't want to wash my clothes because I feel so many bad things has happened. I can't just get up to wash those clothes. I know, even as a therapist, I know that I'm going through a bad time. I know. So it is because of my mental health awareness. I know what's wrong with me. I know when to get up and just, tell myself, oh, it's enough, Joy, it's enough. Let's just do this. Cry if you need to, but do this. There are sometimes I talk to myself. There are sometimes I talk to my supervisor. I call my supervisor in Croatia. I tell him, doctor, look, this is what I'm going through at the moment. And he talks to me. It tells me some things and I'm able to pick up again. So even as a practitioner, you can go through traumatic experiences as well, whether it is from the past or from the present. Something can just trigger it, okay? So you need to ask whether the trauma is related to their current difficulties, whatever that difficulty is, all right? So you check their current safety, freedom from abuse. So if the person is going through violence somewhere, you should know whether this person should be referred to a shelter. You should know whether this person should be sent to NAPTIP. You should know whether you should call feeder. So you should know, you should check the current safety of your clients, all right? So yeah, check the person's emotional states at the end of the session. You should always do that. Even if your session is once a week or once in 2 weeks. Don't worry, I guess we'll have another session where we'll talk about how to work as an online therapist. So you should check the emotional states of at the end of your session. Know how the person feels, know how the person feels. Give them assignments as well. Give them assignments. Give them something to do that they know that when they are coming back for the next assignment, they have to report back to you. Give them simple assignments. Tell them to write a story. Tell them to write down their experiences. This is just between you and them. You get. Tell them to talk about what happened. Talk about how they felt when such a thing now happened. This is between you and your clients. So you should know what to ask as your session progresses. All right. So also offer a follow-up appointment. Yeah. So you should always use your scheduler. I like to use Calendly. I use Calendly app to schedule appointments. Yeah, I tried Setmo. Setmo did not work. I'm just talking about some apps that I use to schedule. Okay. Setmo did not work, but I use Calendly. Calendly works just fine to schedule follow-up appointments. For my sessions, I don't use Zoom. There's a special app I use for consultations. I use Signal. You might not know it, but it is very, very effective and you cannot crack it. Signal is also a very good place for appointments as well. So I've just given you some tips. We have 7 more minutes to go. This time I want to hear from you. I couldn't finish up my slides, but I'm sure that we would have other time to talk about a lot of things as well. Okay, there is still so much that we should have done, but I would want you now to say some things. Tell me a lot of, I want to hear your feedback, all right? So I'll be opening up I'll be opening up your microphones so that you can speak, all right? So if you want to say something, you can raise up your hand and I would ask you to mute, okay? Yeah. Okay, first here, I'm saying Adebimpe Opola, all right? Where is Adebimpe Opola? I can't find you anymore. Yeah, you will get the slides. You will get the slides, don't worry. You'll get the slides. That will be after the, I think, after the physical presentation, because I would like to teach a lot before you all get your slides. Okay, I can't find Adebimpe.
Hello, I'm here. Hello.
Osasu?
Yes, I'm here.
Okay.
Yeah, good evening.
Hello.
Okay, good evening, Adebimpe.
Okay.
Good evening. These are the people, Pola.
Yes, go ahead.
Okay, good evening, Ma. Thank you for a very informative session. Thank you so much. Just a quick question. You said something like when you are someone that might get so emotional when you are dealing with a client. What if you are this kind of person that's so emotional? Is it wrong to cry with the client when the client is crying? How do you handle a situation like that?
If you are a very emotional person, you have to train yourself. You have to train yourself to be able to handle your emotions. Emotional intelligence in mental health is very, very key. So you cannot just lose your emotions anyhow. So you need to train yourself to gain control of your emotions before you get into therapy. All right? So just do some exercises to help you train yourself, yeah. All right, please mute yourself. Let me call the next person, thank you. Osasu?
Yeah, good evening. Such an insightful class. Yeah. So the question I want to ask is that what about if you have a client that is a widow? She lost her husband years ago and lost her son few months, less than a year. And she's been able to recover, but sometimes because of some situations, those things, those thoughts comes up again, and you see her crying, you see her, sometimes how do you, when such a client comes to you to like, oh, sometimes she does not even know how to get over this trauma, and maybe sometimes one of her children offends her, she thinks about her husband, her late husband, and how do you talk to her to try to get over this?
Okay, so you find out things that she believes in. There are sometimes if you have to go spiritual, if the person holds on to spiritual things, the person is free to use that. She needs to find something that she believes in, something that gives her hope. Because the idea is to show her hope from her current situation, not baseless hope. If you heard me talk about that, what is the future from this now, from her present? Okay, so what does she believe in? Let her hold on to that. It's a good thing that she comes to you to cry. If she can come to you to cry anytime it's going on, you are doing a good job. Know that. It is okay for her to come to you to cry. Don't stop her from crying. Let her cry. But when she's done crying, show her the hope. If it's her children she believes more in, show her the hope of the bright future of her children. If she believes in God, show her. If she believes in remarriage, let her see the hope as well. Okay? But do not give them baseless hope, and always allow her to cry. She's doing a good job. She will eventually get stronger.
Thank you.
You're welcome. Okay, I'm seeing Lois. Lois, please unmute your microphone.
Good evening. Thank you for the session. At what point do you know that the client is healing? Because his mental health and his trauma-informed care is care. And as you continue to give therapeutic sessions, you're supposed to see whether there is an improvement or there is not. At what point do you know the client is healing? At what point do you know you need to change approach if you're not seeing the healing that is expected? Thank you.
All right. So now you are a therapist. You knew how your clients came to you. You knew how they reacted to things. You should be able to notice positive differences. Okay? You should be able to notice positive or negative differences. When you begin to see negative differences, you know that you should change your approach to things. Ask them questions. Remember, you cannot assume. If the person is acting in a way, ask them why they are acting in that way. The good thing is that they have started to talk to you. Okay? If they are not talking to you, find a way to talk to the person, or to get them to talk to you nicely and softly at their own pace. Then, if they are making positive changes, you can see that they are healing. It's a good thing. Maybe they have stopped drinking. Maybe they have stopped some kind of negative behavior. Now you can begin to offer new activities that the person can do to increase that positive side to them. So this is you and your client. You have to be very sensitive and very much aware. All right, next person. I'll just take one more question. I've passed my time so that the next lecturer can come up. Isaiah Ngwene. Isaiah.
All right.
Yeah.
Can you hear me?
Yes, go ahead.
Good evening. Yeah, it's Isaiah Gwene. All right. I just have straightforward questions. You wanted talking about induced trauma. I don't know, something like that.
Oh yeah. Yeah.
Then again, these depression and trauma, can they be said to be the same thing?
Okay.
Just like I said, you don't have time. I have other questions, but it's okay.
Yeah, don't worry, we would have much more time to do more. I just hope Dr. Osaze give us more time to discuss this. Well, as therapists, we still have one-on-one sessions because I would have to supervise a lot of things that you are doing. You still have to come and ask me questions as well. So it's always open. We'll always work together. So yeah, you can get traumatized by hearing another person's trauma. You can get traumatized by hearing too much traumatic cases. First of all, it will weaken you. It will get to your spirit. That is why you always need to hold your own therapy sessions with your supervisor. So hearing a lot of traumatic experiences will get to you, whether you like it or not. You cannot, in fact, you are a human being. You are not wood, okay? You have a soul. Yeah, so it will get to you as well. So you talk to your supervisor when it gets to that. You hold your own traumatic sessions as well for yourself this time, okay? You do activities that you can use to let go. If you need to go and shout somewhere, find your own safe place. You have to find your own safe place where you find your own happiness and where you know how to let go. If you need to shout, if you need to do activities, if you need to go to the gym, if you need to talk to your supervisor, you have to do all that. Yeah, depression is a reaction to events. It's a traumatic reaction, okay? It's not the trauma in itself. It's a traumatic reaction, okay? Yeah, so when you see somebody is depressed, somebody is traumatized somewhere. Something has gone wrong. All right, so it's past 8. I think there's another speaker coming up. Let the person do that. Don't worry, we have more time, okay? Thank you all very much. You can unmute your microphones and I will see you some other time. Okay.
Okay, thank you. Ladies and gentlemen, I want to believe that it was an exciting moment. We're having more of this moment, and it will also interest you that we'll be creating a time for us to meet physically in every state capital, and in any other country we have some good numbers, maybe for a day or two to meet together with and have a practical session with 1 or 2 experts. So don't worry, it's going to get more exciting over time. Tonight we'll be talking to Emmanuel Avertse. He works with the Nigerian Red Cross. He's going to talk to us about CPR and possibly demonstrate to us about how to go about this. And Emmanuel Avertse, are you around? Okay, he's around. So I'm going to hand over make him the host so that I can take over the program right now. And or I can unmute him and let me unmute him. Mr. Emmanuel Avertse, I have unmuted you. Please go ahead and take the floor.
Good evening, everyone. You need to grant me permission to share my screen from this end.
Okay, let me make you the host then.
All right then.
Okay, over to you.
All right, good evening, everyone. I'm Emmanuel Avertse, like he rightly said, from Nigerian Red Cross, a safety and first aid instructor. So for these few minutes I'm going to spend with you, we'll learn little life-saving skills that pertain to daily emergencies that you see around your home, your work environment, and anywhere you might find yourself. Like we always say, emergencies don't announce when they happen, and we're always expected to be prepared to at least give our little support to save lives. So the training is going to be very, very interactive. I'm going to learn from you, and then you also learn from me. So before we start, I know most of us have heard about first aid. We have attended classes and all. So for these few minutes, I'm going to take you, we'll have a platform we'll be working with. We call it the Slido app. So if you have your phones or your laptops, you can just quickly log on to slido.com, and then you enter the code 510862. And then you can just type a little expectation. What, at the end of this few minutes I'm going to spend with you, what will you want to gain? So at the end of the session, we'll carry out a CBT to see if actually we met your expectations and all. So I'll just give 4 minutes for us to log on to that. And then if we have up to 3 or 4 views on expectations, then we can move forward. So you just log on to slido.com, and then you enter the code 510862. You can use Chrome. It's very good with that. And then you type in what, okay, no, you can't. This is the code someone typed in, but just type in, this is the code 510862. It's also at the left-hand corner of the screen. So you just type your expectations and then you send. So if you have up to 3, then we can move forward. Okay, I can see 4 participants already typing. So after the training, we'll have a CBT to see if we have met your expectations. So don't log out of the app. Okay, someone said he wants to learn how to give CPR. Another said learn the basics of CPR, good. Someone said acquire more knowledge on first aid delivery. Okay, that's very fantastic. And that's what we're going to learn for today. Thank you, thank you. Let's move forward. We'll go look over this maybe when we end because of our time. But thank you all for logging in to participate. We have a CBT that will use the app also to do that at the end of the session to see if everything we have spoken about, we got it. All right, so we'll start. So we'll be talking about first aid and CPR. So I'll just do a brief introduction and then I'll play a video that will explain aspects of first aid, how actions at emergencies, what are the actions that are required of a skilled first aider or a skilled safety officer to carry out emergencies. We have the training objectives and then your own roles as participants. So if you check the screen here, we have 3 children. I wouldn't want anybody to be on the first child, which is share and forget. For everything that will be done here, there will be slides played and explanations thrown to them. There will be practical sessions, a little clip demonstration on CPR. I will expect everybody, whatsoever I'm doing on that clip, you should be able to do the same thing when a real life emergency happens. So don't just look at it and then see that this is what I'm doing. So what I expect is, if I'm lifting someone's leg this way, I'm turning someone's body this way, you should be able to understand why that body is being turned that way or that leg is being moved that way. So when the real life emergency happens, you'll be able to do the same thing and then save and promote life. So enjoy the training. So when we said first aid, many people confuse first aid. They'll tell you is the first assistance given to someone who is suddenly injured before taking the person to the nearest medical facility. But first aid is way beyond that. First aid is the initial skilled assistance given to someone who is injured or someone who suddenly takes ill before that person is being rushed to the nearest medical facility. By this, I mean that if I should ask this question, when an emergency happens, many people rush in to assist. You say yes. And if I should ask again that many people rush in to assist, but the kind of assistance they give, they're going with the mindset to save lives, but the kind of assistance they give in turn cause more damage to such casualties. It has happened so many times that in most emergency scenes, you see people rush in and the next thing, someone holds his leg shouting, my leg, if people should help me, I'm dying, my leg, if people should help me, I'm dying. And it's that same leg the unskilled first aiders will now drag into the vehicle. their main aim is, let's try as much as possible to quickly rush this person to the hospital. Not knowing the leg you are dragging, maybe there is a simple fracture, the bone is broken inside. And a fracture, a broken bone is sharper than the razor blade you see outside. So there's a way you may move someone's leg that at the initial point, nothing must have happened to the ligaments and tissues that were damaged. But for you dragging that leg at that point, you end up cutting ligaments and tissues that were not initially damaged at the actual emergency scene. So always advise, as skilled first aiders, you must be skilled in every assistance you are giving. So it means once an emergency happens, any assistance you are giving, you should be able to explain what you are doing to anybody who may come around. Because we are always called, there's a difference between first responder and then a first aider. A first responder is someone who just responds to an emergency, immediately it happens. But a first aider is someone who is skilled in the field of giving initial assistance to casualties who they meet on field before taking such a person to the nearest medical facility. So first aid is way beyond seeing blood and stopping blood, or seeing a broken bone and then trying as much as possible to immobilize and all. If you have someone who lost a loved one and you are there giving words of reassurance or comforting that person, we also call that first aid, though it's called psychosocial support first aid. So it could be emotional support, or it could be the physical aspect of you trying to render assistance to a casualty. So you must be skilled before you give first aid. If not, you are giving the unskilled first aid. When it comes to aims of first aid, there are three basic aims. Sometimes we even call it the 3 Ps, where we have: 1 is to preserve life, 2 is to limit worsening of the casualty's condition, or you could term it to prevent casualty's condition from getting worse, and then 3 is to promote recovery. We always say, as first aiders, once you go into the field, you're automatically doing these 3 things. It's just like someone is bleeding, and you're able to rush in and then hold the affected hand and then pad very well and then bandage. You know for sure that if someone loses a lot of blood, shock will set in. And if nothing is done, that person could go into an unconscious state. And the worst kind of unconsciousness is the one caused by bleeding. Because for that casualty to even resuscitate, you will need to introduce blood to that casualty first before the casualty could even have the strength to start resuscitating. So if you are there and you are able to pad very well and bandage, 1, you have preserved that person's life, because if the person loses more blood and goes unconscious, there's every probability of that person dying. But if you are there and you are able to stop that bleeding, you have preserved that person's life from leaving this earth. And then limiting worsening of the casualty's condition. For the person to bleed more and then go into an unconsciousness, for you to control that, you have already made that person not to go into the next kind of emergency, which might be the unconsciousness. And then promoting recovery. Definitely, once you pad very well and bandage, clothing takes place underneath, and then the person recovers and bleeding stops. So you're automatically doing these 3 things once you go in to save a life. The responsibilities of a first aider we should take note of. 1 is safety. Because I'm a first aider doesn't mean I'm immune to an emergency. If I should rush in carrying out tasks, people have died so many people have left this earth because of this singular act of playing. Emotions plays a lot in emergencies. You want to save life and all. It has happened even in Lagos. For some of you are in Lagos, there's a popular beach called Elegushi Beach, where someone who in all his life had never for once gone through any water body. But someone who was supposed to marry just 2 weeks to the marriage, she had been swimming all her life and all, told this guy that she wanted going to the Elegushi Beach. The guy said no, that he has never been into any water before, that he can't swim. She said no problem, that he can watch her while she swims. They went to the beach, and if you have been to that beach, there's always a commercial section and then the private zone where they tag it with a red lining and tell you it's a danger zone, you're not expected to go. This lady came with this guy. Okay, why not stay where at the commercial section where the safety guards are always there to watch those who don't know how to swim, who try to go into water. But she said it's the private zone she wanted because of her privacy and all. This lady went into water swimming, and you know how ocean current works. One heavy wave took her to the deeper side and he started drowning. The same innocent guy that had never been into the water body, it was the same innocent guy this lady was calling, because to her, this is the person she's going to marry, so he's supposed to protect her and all. This guy, like I told you, emotion sometimes plays. If you are not trained yourself very well on emotional intelligence, it plays so much in emergencies. He rushed him, my soon-to-be wife is about to drown, rushed in to assist, and a heavy wave took her closer to the lady. And because of survival instinct, because people who are drowning, anything they get hold of, their whole life depends on it. This lady will climb on the guy's shoulder and take oxygen, and the guy was just down taking water. Until the safety guards noticed what was happening, they were able to pull the two of them out of the water, but the guy gave up because of too much intake of salty water. And now the lady is married with 4 kids. So you could see, sometimes your safety as a first aider should be your paramount concern. If he had left out emotions, not allowed emotions to play, he would have called safety guards and they would have rushed in to assist this lady, and the two of them would have been married. But life continues. Can't say because the lady lost him, he can't move on with her life. She definitely have to move on with her life. So we say your safety is always there. If you leave this session today, 1,000 lives will be tied to you as a first aider. And it's because of one life you lose yours. It means you are endangering 999 others. So it's because of one life you lose yours. It's better you stay safe and then save more lives and all. Because the knowledge you acquire now, you'll be shocked when you start discussing with your friends. You'll be shocked at what they will do to you when you're unconscious and all. Some will even kill you unknowingly with the actions they will carry. Then we say your next is to assess, check the condition of the casualty. Then you diagnose, look out for signs, ask where the casualty is having pains, discomfort, and establish the problem. Treat. In treating, we mean you provide the appropriate first aid treatment to any casualty. So you are not just giving an assistance, but you are giving the appropriate assistance because certain assistants are different for certain emergencies. So you can't carry an assistance for casualty A and give to casualty B. You might be doing the right thing, but on a wrong casualty, and it might endanger that person's life. Just like in the case when, if I should ask here, if someone, maybe, let's say, I have Thomas here, Thomas Otokpa. Let's say after the session, Thomas Otokpa said he wanted to take us out to eat roasted fish. And then on getting there, let's say Osasu said, told Thomas that he knows a very good joint that we can eat that roasted fish. On reaching there, maybe Thomas has not eaten the fish in Osasu joint and decided to eat the flesh and then test the bone to see if the ingredients were inside the bone. You discover that at the point of eating the bone, maybe Thomas, because of taking that bone, it gets stuck in his throat. And if I should ask now that what are we going to, all of us here, what assistance are we going to render? You see so many people saying, bring Eba, bring Semo, bring all this, and then give to Thomas to take. That's the unskilled way of doing that. You can't push a bone to go down the trachea. It may end up harming the trachea walls. Rather, what we always tell you is, you bend the right appropriate assistance or treatment to give to that casualty. You bend the person down, encourage the person to cough. You give 5 back blows. If it doesn't cover, then you engage what we call abdominal thrust or to push out that bone, not giving a bar. And so some will even say, put your hand inside the mouth and draw out the bone. What if at the point of even putting that hand, you now push the bone to go down the trachea more? For every assistance we're giving for things like choking, you advise everything to come out. So as first aiders, for every assistance you give, it must be the appropriate assistance you give to any casualty. And then we say for aftercare, you keep reassuring the casualty and you provide psychological support. Don't say because I've handled this emergency situation, a secondary condition may not set in. Many times you hear stories of we lost him or her on the way. It's because of the absence of aftercare. Because I bandaged someone's leg or doesn't mean a secondary bleeding may not come. You have to watch at the point, when we talk of aftercare, we say at the point of the incident and the point at which the person is receiving advanced care, that's the hospital, what happened in between. You should take note of that and provide for further medical assistance. Someone is serving life jail term in Kuje prison now because of this aftercare. A friend came in from Lagos who they had misunderstanding, and the two families were aware of their misunderstanding. But when they reconciled, the family never knew about this. And this guy came in all the way from Lagos to Abuja to have to spend time with his friend when they reconciled. Just on the second day of his visit, he started feeling feverish. And the friend said, let them go out and get drugs. They got drugs, gave to his friend. The friend took it, went to the guest room. He went to his own room, only for them to discover the next day the guy died close to the door. And because the family started saying this guy had a misunderstanding, and it was because of the misunderstanding, he lured this guy all the way from Lagos to poison him and kill him. And he could not explain anything because there was no CCTV camera to record what actually happened. But for that guy to die close to the door, it means there was a reaction, a negative reaction to the drugs he took, and he was trying to call for help. And because this guy was not nowhere close, he couldn't reach out to this guy to quickly rush him to the hospital. Aftercare, in this sense, means he was supposed to be with this guy on the same bed. If the guy moves your body and you can't respond, there's the guy calls his name in the night and he can't respond, there's every possibility you start shaking you. And no matter how deep you are in sleep, this person would do what? No matter how deep you are in that sleep, if someone starts shaking you, definitely know there's a problem. And you quickly rush such a person to the nearest medical facility. It's important to carry out aftercare on your casualties. And then in reporting, we said for skilled first aiders, take note of every action they take on field. You report, you take note of every action, because doctors are not spirit. Doctors work with three things. They report you first aiders bring, their experience on field, and then the lab results they get. So if you bring someone to the hospital, there's always this question a doctor will ask you, what happened? If you bring someone to the hospital and you tell the doctor it's stomach ache, when it's actually headache, that's the cause. The doctors may start with treatment for stomach aches. When it's not working, they may resort to lab tests that will show them that it's actually headache that is the issue. But by that time, you have spent a lot of money treating stomach ache that is not there. We gave an award to one of our volunteers because of this after reporting. He came to a market square and all of a sudden the woman started shouting, my stomach, my stomach. He quickly rushed to the woman, asked what happened. The woman said, moi, 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 moi. It was this long August holiday. He quickly asked, madam, what happened to moi, moi? He said, my children. The first aider quickly asked the lady, where are your children staying? She quickly told him the address. Before he could ask of the husband, the woman collapsed. And he quickly rushed to the hospital. The same thing I said, the doctors asked, what happened? He quickly told them that she was complaining of her stomach ache and calling moi, moi and all. And they quickly suspected food poisoning and started treatment for that. I started yielding results. He told them the woman had given address of his two children where they were, if they could release an ambulance with a doctor with him. They were able to release that. On reaching the house, the children were lying in 3 different corners of the house unconscious. They were able to pull the 3 of them to the hospital and started sending treatment, and they were responding. Not up to 3 hours of this same emergency. The husband worked with waterboard close to the hospital and was rushed to the hospital. But in this man's case, when they asked the colleagues what happened, they said he was just working on the plant and then collapsed. They didn't know what happened. Luckily for that man, the doctor on duty discovered the facial resemblance of one of the child that was brought to the hospital with the man. And they started treatment for poisoning, and they were able to resuscitate the family of 5. You could imagine if this first aider didn't extract this vital report from there, definitely those 3 children would have been long gone. And bringing that man before they will run tests or not, depending on how deep the poison had gone, that man too will be long gone. To tell you how important gathering reports on field help. Sometimes it's not even about this, it's about the financial aspect. Because there are some hospitals you go to, they will never give you proper attention before you make maybe a deposit and all. And there may be money lying somewhere with this person's nearest contact. And if you don't extract this, because some casualties, you may be talking to them, the next 5 to 10 seconds, they don't respond again. So you should do everything possible to extract this vital information from them before they go unconscious, so it could help the doctors carry out appropriate assistance and all. So report is very, very important in emergencies. So we have treatment priorities. We say for anything, if you are faced with multiple casualties, the first thing you do is you assess for consciousness Then you go next to the next casualty who is bleeding, then bones, then broken bones, then other conditions. But in the case where you have a casualty with multiple injuries, that's someone who is unconscious. I've seen so many of them. You see someone unconscious, the same person bleeding, the same person having fracture, the same person having bones. So automatically that person becomes your number one priority if you are the only person attending. But we always say for first aiders, and there is hardly you see an emergency that is only the first aider that is there. There's always people around. We always say in every case of emergency, the number of people who usually come to you, triple those who usually come to assist. So you always have people who are there to assist you. Do carry out while you supervise in case where your hands cannot do everything. Now you have known your priorities of assistance. So your professional ethics, you maintain neutrality and impartiality. Now you have known that unconsciousness is your number one priority. Now you went into the field and you saw 4 people lying unconscious. And then one person just had a simple, we call it abrasion, just his topmost layer just peeled off. Nothing happened much. And the person was just shouting, I want to move, I want to move. People should help me, I want to move. And then maybe they are from the east and you're hearing, I want to move. You now leave people who are, 4 people who are unconscious and start rushing to where you are hearing, I want to move. You are not a skilled first aider. So we always attend to those who are seriously injured first before the next people. Then you treat health of casualties as principal concern. We always say you transfer. So for every emergency, you try as much as possible to put yourself in that place. We always say you ask this question, if I'm in this condition, how will I want people to attend to me? Once you have that at the back of your mind, you do everything humanly possible to pull out that person from that situation or give every assistance to assist that person. Protect confidentiality of information provided by casualties. This one is clear. I heard the instructor that was on before me tell you, many people confuse first aiders for doctors. So they may be releasing vital medical information to you. It's not for you to start going to gossip it with other people. You own only the doctor to give that information to and no other person. Because for the doctors, they've already sworn an oath to keep it secret and make sure they treat that person to the best of their ability. So you are not expected to start broadcasting someone's medical condition because he has given it to you and confided in you to do that. Then you are stemmed from any discrimination when assisting casualties. And you have absolute respect for casualties' life, integrity, and dignity. What it means is you do no harm to any casualty you meet on field. I know if I should, we are muted, but a normal first aid kit is always dry. If you are introducing any liquid in any first aid kit, you must be trained on how to use that. It's very, very important for any liquid you are introducing to any kit, you must be trained on how to use that. And the people around should be trained because it happened to an organization that they put this hydrogen peroxide in the kit. And when an emergency happened, someone who was not skilled used it to introduce it to someone's mouth. You could imagine someone in an unconscious state, you are introducing that. The guy died. You can't survive that. No. So for every, you see some people who have all sort of, there was one first aid kit that saw a stethoscope inside. So you see all sort of drugs and all. That one is no longer a first aid kit. They have turned to a mini clinic. For anything you introduce in a first aid kit, you should be trained on how to use that. So I'll pause here and then play a video. We have what we call actions at emergencies. These actions are actions you take when casualties are unconscious breathing or not. You don't give CPR to casualties who are unconscious still breathing. You rather place them in recovery position. You only give CPR to casualties who are unconscious and not breathing. These casualties can be termed in coma. So if a casualty is in coma, it means that's only when you are expected to give CPR. And if a casualty is in stupor, that's when you place them in recovery position. The video here will play that and then we'll end our session. So let me play the video. The Dr. ABCD principle. The D stands for danger. You can bring camera down. So we have a casualty here.
We have a casualty here. Anything could trigger this casualty to go unconscious. And it's right for you as skilled first aiders to know what has really happened to this casualty. And for you to achieve that, you have to carry out actions as emergencies, which is doctor A, B, C. Now, the D stands for danger. It means for every case of emergency, you have to check for danger. Danger for yourself, danger for the person who is involved, danger for those who are around. Because we say in every case of emergency, the number of people who usually come to view triple those who usually come to assist. So it's important to check for all this. Check for all this. And how do you do that? We say in checking for danger is either you remove danger from the casualty or you remove the casualty from danger. And how do you do that? We said, now take for instance, I was with him in the room and we were watching a football match. And then I went out to get some drinks for us to take and enjoy. And then on coming in, I saw him lying this way. First aid says, if this person is my brother, my wife, or my sibling, I'm not expected to just quickly rush and touch it. What if, as I stepped out, he was maybe updating the match details to his friends? He was updating the match details to his friends online who were not watching the match live. And then at a point, someone else shouted him down and asked him online that, who has called now, or who is winning? And then wanted quickly typing who was winning to his friends online. And then he discovered that his phone battery was going low. And then he quickly went to plug it. And maybe this, at the point of doing that without rushing nature, we had a naked wire. Maybe the extension was cutting the naked wire. Because of that rushing nature, he quickly rushed and then touched the naked wire. What will happen? He will receive an electric shock. And if I come in that way and I rush without checking for danger and touching, the next thing is what? I will receive an electric shock also. So nobody will be there to assist. So first aid says when you approach, check. Now in this case, I've seen his hand there. So what I'll do is I'll quickly switch off the power source. And once I've done that, I've remove danger from me. Now, some accidents happen sometimes on the highway and all that, and the place is too tight. Like the last one that happened on the highway, the Mokopolo had an accident on the bed, and then people rushed into her. An incoming trailer, not knowing what was happening at the bed, came and smashed those who were involved, those who came to view, and even those who came to assist the casualties. So the right thing you need to do at that point is what? You move that casualty to a central location before attending to that casualty. If you have done that, you have remove casualty from danger. The next response is what? Is to respond. Now, elicit a response from this casualty. You are done with the D now. You are on the R, which is what? Eliciting for response. You elicit for response from this casualty. And how do you elicit for response? You say you use the COWS method. And the COWS method, you say, C stands for can you hear me? O stands for open your eyes. W stands for what's your name? S stands for squeeze my hand. And then, how do you do that? You say you with your own hands here, you tap on the casualty's shoulder, gently tap. Can you hear me? So open your eyes. What's your name? And then you do something like this. And you say, squeeze my hand. The last one I did, the lady did something like this. She was unable to squeeze my hand, but she did something like this. With that, I knew she was unconscious, still breathing. Now, the reason why we are carrying out all this is for what? Us to know if the casualty is unconscious breathing or not. If the casualty is in stupor, it means the casualty is unconscious breathing. If the casualty is in coma, it means the casualty is unconscious, not breathing. So as skilled first aiders, what do you do when you notice any sign? You have to quickly place that person in the recovery position. And you know, our universal language of communication is English. But you may be responding to a casualty that doesn't understand English. That's why you say you tap the shoulder. But there's some casualties, as you tap, open your eyes, instead of their eyes opening, is a hands that will flip open and close. sometimes you see the leg moving. So at any point, that's what we say, carry blue check. Blue check means you check from the head to the toe, from the toe to the head as you are listening for that response. If the tentative response on any side, you stop and place in proper position. If the tentative doesn't respond, then you move to the next acronym, which is A, airways. We say in every emergency, there's presence of shock, and depending on that shock wave, it causes collapse of airways. And that's why most times when you approach an emergency scene, you see people lying in their head this way, or this way. It's important as chief hospitals, once you approach that, you must do everything possible to open up the casualty's airways. If not, you might be working on the casualty that belong there. So how do you open the airways? Say with your 2 hands, you go to the head, and then with this at the chin, you do what we call the gentle chin lift. Once you do that, the airway is what? Cleared. And then you go to the next acronym, which is B, checking for what? Breathing. In checking for breathing, you know, normal medical sciences, they said you check for pulse, but there are some casualties when they go unconscious, it's very difficult for you to get their pulse. So what do? We say you use the acronym LLF in checking for breathing. And how do you do that? We say the first L means you are looking for this casualty's chest rise. The second L, you are feeling, listening to any noise.
Hello, Mr. Emmanuel. Can you hear me?
You are feeling for any breath from the casualty's mouth.
Mr. Emmanuel.
Yes, yes.
Okay, so we are getting a lot of feedback that the video should be expanded. So can you do that?
Oh, okay.
This your slide and show only the video.
Okay, I understand.
Yes, please.
Now the video I'm playing is or I should just do, let me run it live then, because the video I'm playing is a video of an online training, but the video is very small. If you are to enlarge it on your phone, you can just screen grab it and then open it up until it gets to that top right, then you bring it at the center of your screen. That's the only way you can watch the video full.
Okay, so is there a way to share the video with everyone?
Definitely, I'll do that immediately. I wanted typing on the box before.
Okay, all right, guys. The video will be shared.
So what will happen is I will explain. You can just listen. I will explain, but I will now share the video link, this particular one, to everybody, so they can, at their own convenience, they can go through and then see what I'm explaining here.
Okay, great.
Yes.
Go ahead, please.
Okay, then. But like I said, at the top right-hand corner, the video is there. So just go to your, if you are using a phone, it's even easier. Go on top, then enlarge it, and then bring just the video to your screen. If not, at the end of the session, I'm going to share the whole video with you people to listen to. So you can just maybe listen. For those who can't see but can hear, you can note down your questions and then maybe you ask at the end of the session.
Do that with your head facing the bottom.
So can I share my screen now? Okay. So you enable my screen sharing so I can share. Okay. Still not enabled yet. The screen is still not enabled. Enable the other Emmanuel, not the backup this thing. The Emmanuel with first aid. No, that's Emmanuel Wanchuku. There's Emmanuel with first aid in bracket. Okay, thank you.
Body history. You do that with your head facing the body history. What are you doing? If your head is facing this way, you are doing the three things. You are looking for chest drive, you are looking for listening for any noise from the casualty sound or boost, and you are feeling for breath at the same time. So you do that for about 5 to 10 seconds to know if the casualty is breathing or not, because this is a state at which takes you to the CPR, which is the chest compression. So you must be sure your casualty is actually breathing. It's not breathing before you go to chest compression. The casualty is breathing at this stage. You have to take that position. So let's check our casualty for 10 seconds to see if our casualty okay, for this casualty, the chest is not only rising, the stomach is also rising. And the air is not normal, it's very hot. Air is nothing much conscious. If you try to control this casualty, the two of you will end up fighting. So what you do, once you discover this casualty is breathing, you have to make it in position. Because then what emergency symptom from inside. The important thing is the side at which you are pushing. This hand goes gently to our night. You pick up this hand, this part of the palm of the chin bone, this part. When people go unconscious, this particular part of the palm, and then this comes warm. So nothing even needs to be sustained past this warm. So you don't place this part of the palm on the chin bone, the back part. So you place and you must hold it. Because if you leave this body part working with another part, the casualty has to go back. So you close here and go. Now the legs this way, how to lift it up to a very busty apart. If you start turning them, you may not become a casualty yourself. But once the legs are up this way, you can easily move this casualty to the side without having any difficulty. So with this legs up there, I'll move back a little and more. Turn over this casualty to the side, pull it. Bend it to this side. If the legs are hanging, you have to bring it down for support. And then you go back and then you open up the airways again. With this, the chest is totally off from the ground. And normal breathing.
Okay, from what the feedbacks I'm receiving, let me just explain it. But I think you can hear me more clearly now. So if you can hear me more clearly now, just tap on the chat box. Let me know if you can hear me more clearly. Okay. All right, fine. So I'll explain it, and then when you watch the video, you understand better. All right, so we're at talking about Dr. ABC. I'll just run it down quickly so you understand. So we have what we call the Dr. ABCD principle. This is what guides all skilled first aiders on field to respond to emergencies in order not to harm themselves, to harm those that have gone to assist, and then those who even come to view. Because most times what happens is once you carry out a wrong assistance, it ends up endangering your own life on field. So one thing you need to do is you do away with danger. Like I said earlier, you make sure the area is clear before you go in to assist any casualty. Then you elicit for response. We said the last organ that goes out of a dying human being is the hearing organ. That's why it's very important. Once an emergency happens, you see some people, you watch most of the security outfits, you see them calling off the police. They know why they are doing that, because we have sent so many people to their early graves with the words, negative words. Someone will be in an unconscious state and somebody will come, lift the legs. If the legs falls down, that person is 50% dead to them. If they start shaking your body and you don't respond, the next thing you see somebody shouting at that point, this person is dead. Though. And someone who is struggling with life and is hearing, I'm dead. Why are you even struggling with life? You end up giving up and all. So we say we elicit for response using the COWS method. The C stands for, can you hear me? O stands for, open your eyes. W stands for, what's your name? And S stands for, squeeze my hand. And then you go to the next, which is opening casualties airway. And how do you open casualties airway? We said with the head tilted up this way, and then the chin lift, and then you do this. Because in every case of emergency, there's always presence of shock. And depending on how high that shock rate is, it causes collapse of airway. So once the airway is open this way, it makes it more easier for that person to resuscitate faster. So you open up the casualties airway, and then you check for breathing. You know, in medical sciences, they'll tell you check for pulse and all. But there are some casualties when they go unconscious, it becomes very difficult for you to get their pulse rate. So first aid has made it very easy. How do you do that? We said you take your chin down, the person's mouth and nose, in between that, and then your head faces the body. So you are doing what we call LLF. You are looking for the person's chest rise. You are listening for any noise from the person's mouth or nose, and then you are feeling for breath. At this point, if the casualty breathes and all, then you are expected to place the casualty in recovery position. This is recovery position. This is a position that aids the casualty to recover very fast. It takes off the casualty's chest from the ground with the side. You can see the hand, one of the hands at the chin, and then the first hand goes under 90, then you pull the person to the side which you are, and the person sleeps just like how you sleep in your normal, your sleeping position and all. So you do that, but in this case, you try as much as possible to open that casualty's airway and all. It's only when this casualty is unconscious and not breathing that then you go to what we call CPR. CPR is called cardiopulmonary resuscitation. It's a combination of 30 chest compressions and 2 rescue breaths. And CPR is divided into 3. We have adult CPR, we have infant CPR, and we have children's CPR. The important thing is your compression. It has to go 1/3 deep on the chest. And for you to achieve that, we said it's at the center of the chest you do your compression. So you place your hand at the center of the chest, and then you lock your joints, and then you push in your body on the casualty 30 times before giving 2 rescue breaths. 2 rescue breaths is the one some people call the kiss of life and all. So you introduce 2 life breaths to the casualty, and then you continue compression if the casualty doesn't resuscitate. CPR for children, you use 1 hand in compressing. For infants, you use 2 fingers in compressing the chest. When you have the video link, you'll be able to see every aspect of CPR, the practical demonstration of CPR. But when compressing, we always say you watch the casualty. There are some people, now we are learning that normal ratio of CPR is 32. And then you are compressing somebody, and on the 5th count, the person jerks. I say, wait, it's remaining 25, it's remaining 25. No, what you are trying to tell that casualty is I brought you out from the dead, I'm sending you back to where you are coming from. So even at 1 count, someone can get resuscitated. You're expected to stop and then place that person in recovery position. And CPR is done on only casualties who are unconscious and not breathing. That is casualties who are in stupor, in coma. So casualties who are in stupor are casualties who are unconscious, still breathing. You rather place such casualties in recovery position, the position I showed you earlier on, that enables them to recover faster. And we always say in every case of emergency, you always call your national emergency number. For Nigeria, our national emergency number is 112. You always call that immediately you are approaching any emergency scene. So if there are certain things that will make you to stop CPR. 1, if the casualty gets resuscitated, like I said, you are compressing and the person jerks, you stop. Or you get tired, you're expected to stop. Don't say I'll compress, because last time it happened, someone compressed that way because people were cheering him that he should continue. They see he's doing a good work. He compressed until he fainted on the casualty. When we came, we carried him at the casualty. It was even at the hospital we discovered the second person was actually a first aider that came to rescue. So don't be that person that will compress, because it takes a lot of energy compressing an adult. So once your energy level is going low, please you step aside. You can get anybody around to do that while you supervise. And then if the environment doesn't permit, don't say because I'm a trained first aider, I must carry out an assistance. There are some cases you go into a response, people around tell you, don't touch this casualty. You are not expected to touch those casualties at that particular point. You're expected to give way and then allow the right authorities to come in, because you might go in to save a life and then it might endanger your own. I will end this session with why it's very important if the casualty, if the environment doesn't permit you to respond to a casualty, you are not expected to go there. Something happened in Abuja. Someone was recently trained and a thief came into Kuje community. There's a community in Abuja called Kuje Area Council. The two thieves went in and then one escaped, and the one that was caught was given the beating of his life until he went into stupor. Someone was recently trained. He even had his certificate in the bag, said, this is my first life practical. And then he went in to assist. People around kept telling him, don't touch this person, don't touch. He said he has been trained, he knows what to do. How can they leave somebody lying this way? And then nobody is there to assist. He has been trained. They kept on telling him, don't touch. He said they should give him reason why he should not assist that guy, or he was going to assist. He pulled out his certificate and started flashing on people's face. And he went in to assist. It was at Gwagwalada Teaching Hospital with his leg hanged up. They told him the person he was trying to assist was a thief, and they thought he came in the disguise of a first aider to assist. Luckily for him, it was only his leg that was fractured. What if he left his head? What will he tell his creator that made him to leave the head? So sometimes the environment will not permit you. We need you to stay alive to save more lives. So don't endanger your life to once you are gone, you have endangered more lives. So your training or your skill as a first aider should make you understand that you are expected to stay your safety first before any other thing. So if environment doesn't permit you to go in to assist any casualty, you are expected to stay clear of that environment and allow whatsoever that is supposed to happen. Just call for help and then wait. Thank you all very much for listening. The video link that will be sent will explain much better everything that pertains first aid and CPR. Because of our time, I will allow us to maybe do that, go back to Slido. We'll just do this little quiz for 10 minutes and then see if we are on the same page or if we have tackled some of the aspects you wanted to learn about. So I'm sharing my screen now. So those who are on Slido already, you can just, what you'll be seeing now is where to enter your names. So just enter your name and then you wait for the quiz. So you always stay on the pool session, because that's where you'll be seeing questions displayed. All right. So quickly, enter your names. Okay, we have 16 people, good. Okay, so what happens is it's just, you have to be fast enough to make your decision on the question for you to be on the leaderboard. And also, if we have up to, I think we have 593. So if we have up to 100 people joining, we can start because of our time. Or let's have 60 people. That's a fair number. We'll start. So we'll end on time. Okay, so the questions will start displaying on the screen. Like I said, just click on the right one and then send. If you have clicked and you discover the question you chose or the answer you chose was a wrong one, you can re-click and then still send. It will still count it right. But the fastest, the better. The faster, the better. And then, okay, let's start. Others can join us the quiz. The quiz is just to make us understand what we have discussed for these few minutes, if we actually have captured it. And then if there's any question after the quiz, we just ask for 5 minutes and we'll take it. Thank you. Okay, so I'm starting now. And it's just 15 seconds. So you have to make a decision very fast. Just 15 seconds. So you have to make a decision very fast or it will log you for that session. All right, so we asked aims of first aid. Let's see the answer. Definitely, it includes all the rest up except making casualties bleed. We don't make casualties to bleed. Okay, we have Fumi leading this session now. Let's go to the next question. Like I said, choose your answer very fast. If not, it will log you out for that particular session. I always try to be on pause. So we say CPR stands for what? Okay, definitely it's cardiopulmonary resuscitation. Okay, it looks like the table has turned up. We have another leader now. Let's see, next question. Dr. ABCD stands for what? All right. Like we said, danger response, airway, breathing, chest compression, defibrillator. A defibrillator is an AED, automated external defibrillator. Okay. Next question. We talked about ratio of CPR for adults. Okay, that's fine. Definitely, we say our ratio is you compress the chest 30 times and give 2 rescue breath or breath of life, like some people call it. Okay, so let's go to next question. We said the following are responsibilities of a first aider except. Okay, we don't give drug administration. Okay, so let's see. We still have Hassan Sadiq leading. Next question, AED stands for what? Okay, good. Called automated external defibrillator. Thank you for those participating in the chat box. I can see your answers also coming in right. Okay, we have Demola leading now. Next question. We just have 5 more questions and then we end. Thank you. I said something about LLF. What's the acronym? What it stands for? Definitely it's look, listen, and feel. You are looking at chest rise, listening for any wheezing noise from the casualty's mouth or nose, and then you are feeling for breath. Good. I can see people choosing B. Yes, B is correct. Okay. Next question. So like I said earlier, in order of priority, If you are the only person responding to emergency, who will you attend to first in an emergency? Okay. Perfect. Definitely, we said is the unconscious casualty because they have very slim chances of survival at that particular point, while the next is bleeding. Okay, we have Abimbola now, bleeding. Okay, next question. We just have 3 more questions and then we end. We said, what's the hand placement for an adult, a child, and then an infant? Okay, perfect. We said adults use 2 hands, children use 1 hand, and infants use 2 fingers. Thank you very much. Okay. I made mention of this. What's the national emergency number for Nigeria? Yes, for Nigeria, what's the national emergency number for Nigeria? In case there's an emergency within Nigeria, what would be your national emergency number? Okay, perfect. I can say, yeah, 112, it's good. 911 is for USA, but for Nigeria, it's 112. Okay, Abimbola is still there. Okay, this is second to the last question. This is like a bonus question. Convulsion is caused by what? Okay, definitely convulsion is caused by the rise in temperature above 38 degrees Celsius. Convulsion is not caused by hunger or oversleeping. Okay. So our last question for this session is this. Cows stand for what when eliciting for response? Like I said earlier. Cow stands for what when eliciting for response from a casualty? Okay, can you hear me? Someone said open your legs. We don't say open your legs. And we don't say squeeze my neck too. Definitely is, can you hear me? Open your eyes, what's your name? And then you squeeze my hand. I think that's the correct answer. So we don't squeeze casualties' legs. We don't tell them to open their legs either. All right, so let's see who won this session. Okay, Abimbola, thank you. Felicia is there, Fumi, Lola, Ademola, and then Fumi. Thank you all for joining. For others, you can also see your positions there. Thank you all for this session. So if you have questions, I don't know if there's time for questions because first aid is more of practicals. Like I said, that's why it's important. I had to pause. It's better you understand it very well. With the video that will be I'll send to you, and then maybe if there are questions, if you have another session, maybe a physical session, it will be nice you attend so you can learn more about first aid and all. This is just the basic. When you come for a practical session, you do a hands-on, and then we learn from each other. Thank you very much. So if there are no questions, I'll end my session for now. Thank you. And thank you all for participating, both those on Slido app and then those on the chat box. It was highly participatory, and I love that. Thank you all.
Okay. Thank you, ladies and gentlemen. I want to believe it was an exciting moment for everyone here. And this is just the beginning. Tomorrow is going to be another wonderful moment. But before I talk about tomorrow, I want to appreciate Mr. Emmanuel Avertse and the first speaker, Joel Ativie. They did wonderfully well. They added a lot of zest to this program. And I want to believe that after tonight, you would have gotten one or two extra things to add to this program we are doing. For Mr. Avertse, who advised that we create a form for you to ask your question, then if we pick those questions, then respond to them, then we'll send them back to the class. We'll do that hopefully over the weekend. So just tomorrow we'll get a form across, just ask the questions you want to ask there so that you can get across to you. Tomorrow we're looking at, just hold on, let me see. Okay, tomorrow is, okay, tomorrow 18, 7 p.m. to 9, we're talking to Mr. George Hemba. He'll be looking at preamble on a mental health counselor, roles of a mental health counselor, basic stages of counseling, skills to develop as a mental health counselor, and golden rule. You just need to come and see the profile of Mr. George Hemba. He's actually in the class. Scroll back is the second person with his picture. Scroll back and read through his profile and the topics you are going to be dealing with. Yeah, so that you get ready. And the link for the Zoom tool will be there. And secondly, this is recorded and it's going to be placed in the classroom on our site. So if you have already been there, all you just need to do is sign in and go straight to the last stage, which is forensic program. And once you get there, you can continue watching this video. You can watch this video on a repeated form several times. You also get some text materials from the first speaker. Then if you've not been there before, please go and create your account there so that you can sign in anytime and study. So for those of you that are not here, this video will be there for you to watch. But if you are here, you can also repeat this video several times. And when you get there by tomorrow, hopefully by tomorrow morning or afternoon, you will get a CPR video that demonstrates exactly how that can be done. Ladies and gentlemen, we've come to the end of this program for tonight. Tomorrow promises to be another wonderful session that is going to be like, wow. Everything is going to be in the same platform on our classroom for your level 3 so that you can go catch up and load yourself with all the knowledge you need to load yourself with and become the expert that you've always wanted to be. Now, let me tell you something. Once you say you have a level 3 certificate and training, people want to see practical demonstration. They want to see action. They want to see the fact that you can actually solve a problem. So it's not about just having that title and the certificate. Now it's about practicing. It's about carrying out exactly what you say you can do. And I hope that with all this we are doing, we'll be able to do a lot for ourselves and make everybody proud here, make Laplace proud, make yourself proud, and make Africa proud too. And hopefully you'll be one of the members of the new society that is going to be created soon. And we'll be looking for jobs outside this country that you can do virtually for those people that will be doing well with their assessment and test. So it's going to be a long journey for everybody that we all be on together. So it's not just going to end up in this class doing level 3. So please be patient and understand that you are dealing with an organization that looks at the future and not now. Thank you, ladies and gentlemen. God bless you all, and good night. Thank you.
Good night, sir.
Good night.
Thank you very much.
Good night.
Good night.